Alopecia refers to a loss of hair from part of the head or body, and it can occur in a wide variety of disorders. Assessment begins with obtaining a description of hair loss and the areas involved, as well as a medical history and family history. Physical examination involves inspection of the scalp and other body sites. Assessment of activity on the scalp can be done with a hair pull test, done by gripping about 20 hairs and gently pulling upward and away from the skin. Normally, about 3 hairs fall out with each pull, but if more than 10 hairs are removed, the test is considered positive. A non-invasive method of examining hair and scalp is trichoscopy, which is performed with the use of a dermatoscope. This traditionally consists of a magnifier, a non-polarized light source, a transparent plate, and a liquid medium between the instrument and the skin. In some cases, diagnostic techniques like microscopic examination of cut or plucked hair fibers and scalp biopsies can provide additional information. The pluck test is conducted by pulling hair out by the roots. The root of the plucked hair is then examined under a microscope to determine the phase of growth, and is used to diagnose if there's a defect of anagen or telogen. Anagen hairs have sheaths attached to their roots, while telogen hairs have tiny bulbs without sheaths at the end of their roots. Finally, getting a scalp biopsy from the center of the lesion gives confirmation of permanent hair loss, whereas a biopsy from the edge or an area of active inflammation can shed light on the underlying disease, and depending on the suspected diagnosis, additional laboratory studies can be performed. Now broadly, hair loss disorders can be divided into cicatricial or scarring alopecias, non-scarring alopecias, and structural hair disorders. Cicatricial alopecias are characterized by irreversible damage to the hair follicle that results in interruption of hair cycling and permanent hair loss if not treated in time. The loss of follicular keratinocytes in the bulge region of the hair follicle is thought to contribute to the development of cicatricial alopecia. A scalp biopsy is necessary to diagnose the type of cicatricial alopecia, to determine the degree of activity, and to select appropriate therapy. Cicatricial alopecias may be primary or secondary. Primary cicatricial alopecias are inflammatory disorders with unknown cause, which might be associated with inflammatory diseases like lupus or lichen planopilaris, and are subdivided by the type of predominant inflammatory infiltrate detected on scalp biopsy into lymphocytic, neutrophilic, and mixed primary cicatricial alopecias. Treatment strategies are different for each subtype. The goal in lymphocytic cicatricial alopecias is to decrease or eliminate the lymphocytic inflammatory cells that are attacking and destroying the hair follicle. Individuals with more localized disease can be treated with high-potency topical corticosteroids. On top of this, individuals with more extensive disease can also get oral antibiotics like doxycycline. Finally, individuals who fail to respond to standard therapy with topical corticosteroids and antibiotics may be given oral anti-inflammatory medications like hydroxychloroquine, mycophenolate mofetil, or cyclosporine. Now, the neutrophilic group of cicatricial alopecias can be associated with pathogenic microbes, even though their correlation isn't well understood. So treatment is directed at eliminating them with oral antibiotics like doxycycline as initial therapy, and rifampin and clindamycin as second-line therapy. Oral isotretinoin is an alternative second-line therapy for individuals who fail or cannot receive clindamycin and rifampin therapy. Finally, for the mixed group of cicatricial alopecias, mild to moderate inflammation areas get high-potency topical corticosteroid therapy and may get a topical antibacterial agent or topical retinoid as adjunctive therapy. On the other hand, individuals with more severe inflammation get initial treatment with oral antibiotic therapy, generally with doxycycline, and should be tested for secondary infection with cultures and sensitivity testing. If they turn out negative, topical corticosteroids may be given as well to help reduce inflammation. On the other hand, secondary cicatricial alopecia always has a known cause. Causes include tinea capitis, radiation therapy, and surgical or injury scars. Tinea capitis is a common fungal infection of the scalp caused by the dermatophyte fungi of trichophyton and microsporum species. The most common clinical findings are single or multiple scaly patches with alopecia. Some individuals may present patches with black dots at follicular orifices that represent broken hairs. In addition, often individuals have palpable cervical lymphadenopathy. A severe manifestation of tinea capitis, known as chirion, results from an intense immune response to the infection. Chirion is characterized by the development of an inflammatory plaque with pustules, thick crusting, and drainage, and it's often associated with tenderness or pain. Biopsy of tinea capitis shows fungal elements within or surrounding hair shafts, and perifollicular mononuclear infiltrate in the dermis, as well as multinucleated giant cells in the dermis in cases where the hair follicle is disrupted. Trichoscopy can help in the diagnosis of tinea capitis, showing broken hairs and black dots. Finally, fungal cultures can be performed to confirm tinea capitis when the diagnosis is uncertain. Treatment involves systemic antifungals like griseofolin, terbinafine, fluconazole, or itraconazole. Adjunctive interventions for tinea capitis include using a shampoo with antifungal properties to reduce the risk of spreading the infection to other individuals. Secondary cicatricial alopecia may also be secondary to radiation therapy administered to the head, and it's most commonly used to treat cancerous growths within the brain, since hair follicles are very sensitive to radiation and enter the telogen phase. Hair shedding may start as soon as 2 weeks after the dose of radiation and continue for a couple of weeks. Secondary cicatricial alopecia can also occur in areas with surgical or injury scars. This occurs when the scar is so deep that it damages the hair follicle permanently. Next up, non-scarring alopecias are conditions where the hair follicle is not permanently damaged, so hair regrowth is possible. In non-scarring alopecias, clinical signs of inflammation are usually mild or absent, and there's no destruction of the hair follicle. Recognition of distribution of hair loss is useful for the diagnosis of non-scarring alopecias, subdividing it as focal, patterned, and diffuse. Focal hair loss can be observed in conditions like alopecia areata, traction alopecia, or syphilis. Alopecia areata is a relatively common form of non-scarring alopecia where an autoimmune process leads to the spontaneous loss of hair on the scalp or other areas. This disease interferes with hair cycling by causing a follicle to prematurely leave the anagen phase and enter the telogen phase. Most often, alopecia areata presents with smooth circular patches of complete hair loss that develops over a period of a few weeks. The course of alopecia areata is unpredictable, as many individuals with limited patchy hair loss experience regrowth within 1 year, but recurrence is common, and a minority of individuals can progress to total loss of scalp hair, which is called alopecia totalis, or even loss of all hair, which is called alopecia universalis. For diagnosis, close visual inspection can reveal exclamation point hairs, which are short, broken-off hairs that are narrower close to the scalp and therefore look like an exclamation point. Performing a hair pull test can also help confirm active hair loss. Trichoscopy findings include yellow dots, short vellus hairs, black dots, tapering hairs, and broken hairs. In addition, individuals with alopecia areata should be assessed for associated conditions, like autoimmune disorders or stress. In most cases, there's spontaneous regrowth of hair. Individuals who want additional treatment may get topical or intralesional injections of corticosteroids if alopecia is limited, while individuals with extensive alopecia can get topical immunotherapy with diphenylcyclopropanone or squaric acid dibutyl ester. Additionally, systemic glucocorticoids are occasionally prescribed as a temporary measure to slow hair loss in individuals with rapidly progressing and extensive hair loss. Now, focal hair loss in traction alopecia results from prolonged pull or tension on the hair follicle, usually due to hairstyles like tight ponytails or braids. That's why the scalp is the most common site of traction alopecia, especially the frontal hairline and the temporal scalp above the ears. At first, Hair loss may be absent or limited to a subtle decrease in hair density, as well as traction folliculitis, which can manifest as perifollicular erythema with inflamed papules or pustules. Scalp scaling and pruritus can accompany traction folliculitis. Traction folliculitis can be transient, resolving as tension on the hair follicles decreases due to the removal of traction or hair growth. Persistent traction can progress from decreased hair density to patches of complete alopecia. A sign of traction alopecia can be the presence of hair casts, which are movable collections of white scale that encircle the hair. Ultimately, traction alopecia can go from being non-scarring to scarring alopecia, leading to permanent hair loss. Treatment involves discontinuation of traction hairstyles. Focal hair loss can also be an infrequent sign of secondary syphilis, called alopecia syphilitica. Alopecia syphilitica presents with patchy hair loss on the scalp, described as moth-eaten alopecia. Hair loss can also occur in other sites. Syphilis can be diagnosed by using serological tests to detect the spirochete called Treponema pallidum, and treated with antibiotics like penicillin. Moving on, patterned alopecia is a common condition with increasing age, most frequently presenting as slow, progressive hair thinning, and a loss in a characteristic distribution on the frontal and crown areas of the scalp, with relative sparing of the occipital scalp. The condition is mediated by the action of androgens on hair follicles in genetically susceptible individuals, and that's why it's called androgenetic alopecia. Androgenetic alopecia results from shortening of the anagen phase of hair follicles, which leads to the production of shorter, thinner vellus hair shafts, a process called follicular miniaturization. Androgenetic alopecia is also known as male pattern hair loss when it affects males, and female pattern hair loss when it affects females. In males, the hair loss often presents itself as a receding hairline that typically spares the occipital scalp. On the other hand, in females, it typically presents as a thinning of the hair, while the loss of terminal hairs in affected areas is usually incomplete, and the frontal hairline is often spared. For women who want treatment, topical minoxidil is suggested as first-line therapy. On the other hand, for men with androgenetic alopecia, oral finasteride is suggested as first-line therapy, while topical minoxidil is an alternative therapy for male individuals that prefer to avoid systemic therapy. Treatment must be continued, otherwise hair loss will occur within several months after the cessation of therapy. Permanent improvement in androgenetic alopecia can be obtained with hair transplantation surgery, which can be performed in individuals who fail to achieve satisfactory improvement with medical therapy or wish to achieve a permanent solution. Hair follicles are removed from non-balding occipital scalp and transplanted into areas affected by alopecia. Patterned alopecia can also be associated with trichotillomania, which is a psychiatric disorder that lies on the obsessive-compulsive spectrum, where individuals repeatedly pull out hairs, most often from the scalp, creating areas of alopecia that may have irregular, bizarre shapes. Episodes of pulling can be triggered by anxiety. Individuals with trichotillomania exhibit hair of differing lengths. Some are broken hairs with blunt ends, some new growth with tapered ends, some broken midshaft, and some uneven stubble. Scaling on the scalp is not present, overall hair density is normal, and a hair pull test is negative. Initial treatment usually involves behavioral psychotherapy, learning to recognize their impulse to pull, and also teaching them to redirect this impulse. Some individuals whose severity interferes with daily functioning can get medications like tricyclic antidepressants or selective serotonin reuptake inhibitors. Diffuse alopecia can be associated with abnormalities of hair cycling. Anagen effluvium occurs as a result of an acute interruption of the anagen phase and leads to extensive hair loss without transition of follicles into the catagen or telogen phase. Chemotherapeutic agents are a major cause of anagen effluvium, since most chemotherapy drugs work by attacking rapidly dividing cells like hair follicle cells. Hair loss typically occurs within 2 weeks of the inciting event, but it's usually reversible, so once the course of chemotherapy has ended, hair regrowth occurs, generally after 3 to 10 weeks. Anagen effluvium shows a decrease in telogen phase hairs and an increased number of broken hairs upon examination of the pluck test. On the other hand, telogen effluvium is a common cause of diffuse hair loss that usually presents with acute or chronic loss of hair due to an abrupt shift of numerous hair follicles in the anagen to the telogen phase. Factors that can cause telogen effluvium can include major physical or psychological stressors, childbirth, dietary restriction, and medications, as well as arsenic, thallium, or mercury poisoning. Hair loss usually occurs 2 to 3 months after the inciting event. Telogen effluvium shows an increased percentage of hairs upon examination of the pluck test. Finally, structural hair disorders are characterized by abnormalities within the hair shafts that result in fragile or brittle hair. This can be inherited, causing abnormal hair formation, but it's most often acquired from external insults that damage the hair shaft, such as harmful hair care practices like chemical processing, excessive brushing or teasing of hair, or the application of excessive heat. Alright, as a quick recap, alopecia may be a manifestation of a wide variety of disorders, which can be broadly divided into cicatricial or scarring alopecias, non-scarring alopecias, and structural hair disorders. Cicatricial alopecias are characterized by irreversible damage to the hair follicle that results in interruption of hair cycling and permanent hair loss if not treated in time. Primary cicatricial alopecias are inflammatory disorders with unknown cause, while secondary cicatricial alopecia always has a known cause, such as tinea capitis, radiation therapy, and surgical or injury scars. Next, non-scarring alopecias are conditions where the hair follicle is not permanently damaged, so hair regrowth is possible. Non-scarring alopecias are subdivided as focal, patterned, and diffuse. Focal hair loss can be observed in conditions like alopecia areata, traction alopecia, or syphilis. Patterned alopecia is a common condition with increasing age in genetically susceptible individuals, called androgenetic alopecia, or it can be associated with trichotillomania, where individuals repeatedly pull out hairs. Diffuse alopecia can be associated with abnormalities of hair cycling. Anagen effluvium occurs as a result of an acute interruption of the anagen phase, which may be caused by chemotherapeutic agents. Telogen effluvium occurs when there's an abrupt shift of hair follicles in the anagen to the telogen phase. Factors that can cause telogen effluvium include major physical or psychological stressors, childbirth, dietary restriction, and medications, as well as arsenic, thallium, or mercury poisoning. Finally, structural hair disorders are characterized by abnormalities within the hair shafts that result in fragile or brittle hair. For diagnosis of what's causing alopecia, assessment begins with obtaining a description of hair loss, as well as a medical history and a family history. Physical examination can involve inspection, a hair pull test, or trichoscopy. If diagnosis is uncertain, individuals can get a microscopic examination of cut or plucked hair fibers and scalp biopsies.